Hi friends, so today we are continuing with biochemistry review from the USMLE Step 1 First Aid book. And in the previous video, we ended on page 83. So if you haven't watched it, please just take some time to go back to those videos and start from there, since we are reviewing all the pages for biochemistry. And in this video, we'll start from the other half of the page 83, but I can't stress any much on this page here. Amino acid derivatives, it's a very highly tested, very highly tested, and you have to know all this, what amino acid is used to produce what, and what vitamin mediates it, or what vitamin is a cofactor for it. And this one is what we are going to look at in the next in the next image. So this is catecholamine synthesis or tyrosine catabolism. So what they mean is that we use tyrosine to make all the catecholamines. The catecholamines are the norepinephrine, epinephrine, dopamine. They are the catecholamines. So we call them catecholamine because they have a catechol ring with an amine group, which is an amino acid, an amine group attached to them. So we call them the catecholamine. So it's catecholamine, and that's where the name is gotten from. So here we are using phenylalanine to make all the catecholamines, or the catecholamines, or all the catecholamines. So phenylalanine will, when we remove some of the carbons from it, when we remove some of the hydrogen, it turns to something else, right? So now let's look here. Initially we have the amino acid phenylalanine, right? Now phenylalanine phenylalanine hydroxylase, okay, hydroxylase, just adding an OH to it. So we are adding OH over here, and then we get tyrosine. So you can see that the difference between phenylalanine and tyrosine is not anything big, but it's just OH. If we have OH, if you just have OH to it, it would turn into tyrosine. So the hydroxylase means that it is adding OH to it, and then we get thyroxine. Now thyroxine can be used to make dopa, and dopa means what? Hydroxylated phenylalanine, because we are adding OH to phenylalanine. Therefore we will get thyroxine, right? Now this thyroxine can be used to make dopa, and that is dopa. Dopa means we've added another OH to phenylalanine. So it means that this thing, which is dihydroxyphenylalanine, is just 2 OH, because if you look here, the enzyme here is thyroxine hydroxylase. It's also adding another OH to thyroxine, so we get 2 OH, another H here. Good. So OH and what? OH. Now the next step is converting dopa to dopamine, and here we do decarboxylation. And we already said that decarboxylation is mediated by vitamin B6, but then carboxylation is mediated by vitamin B7. So dopa decarboxylase means that we are removing a carbon from the dopa, and then we will get dopamine. So minus a carbon, then we get dopamine. It's mediated by vitamin B6. Take note of this because it is highly tested, very highly tested. If I were you, I will keep these two steps here very important. Okay, so we have to know all the cofactors. From the first two steps is BH4, tetrahydrobiopterin, and here is B6. And now the next step is converting dopamine to norepinephrine, the norepinephrine, and it's mediated by vitamin C, and here it's doing beta hydroxylation. So it's dopamine beta hydroxylase. So it's also adding what? OH. So you see, the whole thing is just about adding OH or removing carbon. That's how I appreciate biochemistry, because biochemistry is not hard. We are just playing with all these atoms and elements and compounds, and we are changing their structure in space, and then we are getting different stuff. So dopamine, we add OH to it, and then we get norepinephrine. And why they call it beta hydroxylase is because we are adding the OH to the beta carbon, or the beta carbon, and it's mediated by vitamin C. The most important and the most high yield step here, if I were you, if I don't know anything, I want to know these two steps. These two steps. If you can't keep anything, these two. Because if somebody has vitamin B6 deficiency, they can lack all the catecholamines. And then catecholamines, they make us active, right? Fight or flight. So they cannot have that fight or flight. So they'll be having they'll be feeling sleepy instead of being awake and active, right? And now, if somebody has vitamin C deficiency, also they can also lack anything from below. If they lack vitamin B6, they will lack anything from above here. Dopamine will be decreased and all other things will decrease. If they lack vitamin C, dopamine will be normal, but everything here will decrease. Now, the next step is converting norepinephrine to epinephrine. And then if you remember, SAM is the mediator. SAM is what we saw when we were doing tetrahydro, how do we call it? When we were using folate and B6 to make methionine from homocysteine, that pathway that we discussed in the previous videos. Yeah, so that is where we get we get a SAM from, and SAM is just a CH3 donor. So SAM will give us CH3. It's just one carbon unit. So SAM is donating CH3 to norepinephrine, and then we will get epinephrine. What you want to know is that over here, the enzyme is phenylketonuria and methyl transferase. They call it PTNM. So just take note of that. It's called PTNM. And then cortisol is what stimulates it. Therefore, if somebody has low cortisol state, like in Addison, that is why they can lack epinephrine, will have low blood pressure. It should make sense. If someone, we all know that low cortisol state, Addison, they have hypotension, and this is the reason, because cortisol stimulates PTMN, and low cortisol means that we cannot stimulate PTMN, and then we'll have low epinephrine, we'll have shock. So this step is also very important. Take note. Why, if somebody has shock, we give them cortisol. This is one of the reasons. Now, from here, epinephrine can be converted into metanephrine using the catechol-O-methyl transferase. That is, we are degrading it. This is just a degrading pathway. So using catechol-O-methyl transferase. And also we can also break down this one using monoamine oxidase. It's also breaking it down. So this is the main step from the straight pathway is the main step. This side is just the breakdown product. So that's what we get. Also, we can also break down dopamine into homovalenic acid. Yeah, we'll see the clinical importance of this. Now, we cannot leave this side out. This side of the pathway, we can't leave it out. So this side, on this side, tyrosine can also be converted into homogentistic acid. Then homogentistic acid is converted into mallyl acetic acid. Not very, very high yield to know all this, but you want to know that tyrosine can be converted into homogentistic acid, and at the end of the day, it makes fumarate into the TCA cycle. Now, if somebody does not have this enzyme, which is homogentistate oxidase, they'll have accumulation of homogentistic acid in their system, and the condition will be called Alkaptonuria. And in this Alkaptonuria, what they have is that they have their urine becomes dark when they leave it. So a baby whose urine has been left in a diaper will turn dark. Also, if you look at their bones have black things, and their cartilages all have the black things in them. It's called ochronosis. And so this is homogentistic pathway. And then here you want to know that dopa can be converted into melanin. This is the melanin that gives the black pigment, and it's done by the tyrosinase. So dopa is converted to melanin using tyrosinase enzyme. Now, if somebody lacks tyrosinase, what would they have? You can't make melanin. Therefore, they'll have albinism. So they will have albinism. That is the classical albinism, lack of tyrosinase. Now, we can also have a condition whereby so this one is a classic albinism. We can also have another condition. So you want to biochemistry is such that, like, you want to differentiate what looks like this. We want to differentiate it from the other one. So albinism can also come in another form whereby that one is called the Chidiac-Higashi. So in Chidiac-Higashi, it is not the tyrosinase, but it is rather due to a cytoskeletal transport problem. So cytoskeletal transport problem. Okay, now cytoskeletal transport. So usually, if I want to explain this, you have a cell. Okay, let's say you have a cell here. And what happens? So let's say in the cell we have cytoskeletons that, if this are cytoskeleton, they are like a road that vesicles can use. So in this cell, let's say we have these tiny things that we make melanin in, right? Which are the melanosomes, right? Melanosome. So melanosome. These are the melanosome, right? Good. So in the melanosome, which are these tiny vesicles, after we make the melanosomes, after we make melanin within the melanosomes. So after we make the melanin in the melanosome, we need to transport this to the melanocytes so that we can color them so they become black like my skin. So these melanosomes need to move on. They need to move on these cytoskeletons to go to the melanocytes. Then now, if the person has Chidiac-Higashi and they have cytoskeletal transport problem, they don't have all these cytoskeletons, so they cannot transfer the synthesized melanin to the melanosomes. So they will have accumulation of melanin in the melanosomes, and then the skin cells will now lack the melanin, and then they'll look the way albinos look. Yeah. Now, this is not the only problem in Chidiac-Higashi. In Chidiac-Higashi, for example, if this is a macrophage and then it has engulfed, this macrophage has engulfed bacteria, okay? If it has engulfed bacteria and now it moves into the cell, what happens? We have structures like the lysosomes in the cell that should fuse with this engulfed vesicle with bacteria in it, right? So if assuming that the lysosomes are somewhere here, right? So this is lysosome. If lysosome is somewhere here, and then the engulfed vesicle is also here with bacteria in it, right? This with bacteria in it. We need these same cytoskeletal proteins, right, for the transport. We need them for the transport. If we lack this cytoskeletal or transport mechanism or pathway or cytoskeletal proteins, then it means that we'll have our neutrophils, macrophages, they will have engulfed bacteria within them, but then the lysosomes cannot fuse They cannot move to go and fuse with them. Therefore, they cannot destroy the bacteria. The bacteria will just remain in the cell. So we have accumulation of substances within our neutrophils, for instance. So the neutrophils, they'll say that they have large deposition of structures, although they'll always describe the question that there on microscopy there are large something, there's a large substance within the neutrophils, plus albinism. So they'll describe that as the person has a pale skin, or they'll describe, you know that the person is presenting with albinism, and then that will help us to differentiate this type of albinism, the Chidiac-Higashi type of albinism, from the tyrosinase deficient, the classical one. Okay, now let me just chip in this, because I told the USMLE always wants you to differentiate things. They don't want you to just know things in isolation. We also have another condition that you want to differentiate from Chidiac-Higashi. So Chidiac-Higashi versus Wiskott-Aldrich syndrome. Okay, you want to differentiate the two. So we've seen the Chidiac-Higashi is due to cytoskeletal problem, whereby things cannot travel within the cells. Now, in Wiskott-Aldrich, what they will present is that they will also present with infections, chronic infection, just like Chidiac-Higashi, because Chidiac-Higashi cannot destroy they engulf bacteria, so they'll have chronic infection, but they will also have albinism. But in Wiskott-Aldrich, they have chronic infections with eczema. So they have eczema as the presentation. So you want to know the difference. So anytime you meet these two questions, Chidiac-Higashi, you are looking for infections with albinism together. But in Wiskott-Aldrich, you are looking for infection, someone who has chronic infections with eczema. Okay, so we can continue from there. So now in this, we have been able to differentiate classic albinism from Chidiac-Higashi, and also Chidiac-Higashi from Wiskott-Aldrich syndrome. Okay, now let's continue. The next problem I want to look at is PKU, phenylketonuria. So phenylketonuria is accumulation of phenylalanine in the urine and blood because there is deficiency of the enzyme phenylalanine hydroxylase. So we cannot convert phenylalanine to tyrosine. Therefore, we will lack all this stuff there. All the catecholamines will lack all of them. So this person, if we know how they will present, because they will not be active, they'll have mental retardation and all that, because we need all this epinephrine to keep our mind sharp. So phenylketonuria, they'll have all these mental retardation symptoms, and they'll have hypotension because we need epinephrine to have high blood pressure, we need dopamine, and we'll have accumulation of phenylalanine in the person's urine. So let's go to the next page, and then where they describe all these things. So phenylketonuria, so we've seen the general overview already. It's caused by deficiency of the phenylalanine hydroxylase enzyme and or deficiency of tetrahydrobiopterin. So if you look over here, when we have lack of tetrahydrobiopterin, right, what happens is that when we have lack of this, it can also lead to phenylketonuria, because this enzyme phenylalanine hydroxylase needs this. So in the Q banks, what they do is that they know that most people know phenylketonuria has to do with phenylalanine hydroxylase deficiency, but then they also want you to know that BH4 deficiency can also lead to the same thing, because both of them control this pathway. The same way here also can also be like that, because if you have BH4 to affect here also, we have decreased dopa and everything, dopamine and everything will also be affected. Yeah, okay. So it's due to deficiency of phenylalanine hydroxylase and also the enzyme, and also BH4, which is the cofactor. Tyrosine becomes essential, very, very important. This is highly tested. Why? Because if somebody has someone has deficiency of this enzyme, tyrosine will not be available. But we also know that tyrosine is not an essential amino acid originally, but now it becomes essential because the body cannot make it. If the body cannot make it, we need to eat it to get it. So the people who have PKU, we need to feed them with tyrosine. So that's why they say tyrosine becomes essential and there's elevated phenylalanine. This will lead to phenylketones in the urine. So phenylalanine will be converted into phenylketones in the urine. Findings are intellectual disability, as I said, microcephaly, seizures. To have hypopigmented skin. Why? Because we need tyrosine to make melanin, and then here we are lacking this. We are blocking this place, so we cannot make melanin as well. So they will have hypopigmented skin. They'll have eczema. They'll have musty odor, and then they'll have musty body odor. Then their urine will also be musty urine as well. Yeah. Now treatment is, since it's excess phenylalanine that is causing all these symptoms, we have to decrease phenylalanine in their diet, but we have to give them tyrosine rather. So increase the tyrosine but decrease phenylalanine. We also give them tetrahydrobiopterin supplements. Even if they lack, they are deficient in this enzyme, it doesn't mean they lack it totally. So if we give more of BH4, the little of the phenylalanine hydroxylase that we have will be able to work, and that can make the symptoms milder. It's autosomal recessive. You want to know that because we said most of the enzymes are autosomal recessive. And so maternal PKU is due to elevated maternal phenylalanine levels and can be prevented by dietary intake. Findings in the infant: microcephaly, intellectual disability, and growth restriction and congenital heart disease. Yeah. Okay. Now, this is the pathway. We have the classical one, which we talked about, which is the PKU in the child, and also the mother can also have that. So let's take note, and then they'll have deficiency of all that, so they grade all of them out. They'll all be deficient, and that makes a lot of sense. Now let's go to maple syrup disease. I talked about this in the previous video, but it's good we are meeting it here. So in maple syrup, there is blocked degradation of branch chain amino acids. And then if you remember the mnemonic that I said what? If you remember, it was a song that I sang in the previous video. I'm going to sing it again. It's pro-gaff peel fierce water. Veal has a branch. His lies are so basic. L and L ketones. So again, I'm going to explain. Pro-gaff peel means that what? Pro-gaff peel means that, like these amino acids, because they fear water, so they are hydrophobic. Therefore, they are going to be what's found in the cell membrane, because the cell membrane has phospholipid bilayer, which is hydrophobic. It has a hydrophobic part. So this pro-gaff peel amino acids will be hydrophobic and they'll be found in the cell membrane. So usually, if they tell you amino acid is found in the cell membrane, it is the pro-gaff peel mnemonic. I'll leave it in the description. I'll leave the description of this in the description of the video. I'll leave the mnemonic in the description of the video. And then the next line of the song was veal has a branch, and this veal, V-I-L, they are the valine, isoleucine, and leucine. They have a branch. They are the branch chain amino acids. So these branch chains need to be degraded by alpha keto acid dehydrogenase. And the vitamin B1, we said all the dehydrogenases have what dehydrogenase complex enzyme, and B1 is one of them. So it causes increased alpha keto acids in the blood, especially those of leucine. This is also highly tested. Maple syrup. So maple syrup is due to what? Increased veal amino acids, because these veal ones cannot be degraded because the person lacks alpha keto acid dehydrogenase. And then treatment is restriction of the veal, VIL. We restrict these amino acids, and Also, we can give them thymine, because thymine is a cofactor for the dehydrogenases. So if we lack the dehydrogenase enzyme, and just as I explained earlier, it's not that we are lacking it totally, but it's just deficiency. It's deficient. So if we give B1 to them, which is thymine, they can the little that they have can work and degrade the veal. So remember the song, pro gas peel fierce water, veal has a branch, his lysa so basic, L and L ketones. Yeah, they want you to know all of them. They test them randomly. It can be any of them. The answer will be any of them. So that's why I put them in a song form. Yeah, and there's a mnemonic for it. I love maple syrup, but I like my song. Now, Alkaptonuria. We saw Alkaptonuria up here already, and then we discussed it. We said it's due to homogentistic oxidase. Yeah. So, and I used this as my name on Facebook because I was forgetting the whole pathway. I started the USMLE before I came across Alkaptonuria. So I used the name homogentistic Alkaptonuria tyrosine. That is what I did, because we use tyrosine to make homogentistic acid, and then the enzyme is homogentistic oxidase. So my name on Facebook is homogentistic Alkaptonuria tyrosine, and with that name I'm not going to miss this question, never. Okay, so congenital deficiency of homogentistic oxidase, as we saw in the pathway, in the degradation pathway of tyrosine to fumarate, leads to pigment forming homogentistic acid buildup in the tissue. It's autosomal recessive, usually benign. Findings are bluish black connective tissues. So the ears become bluish black, the ear cartilage, the sclera, the same thing, that's ochronosis, and sometimes the bone even. Urine turns black on standing. So they'll tell you a mother change the daughter's diapers, and then the following morning she saw that the diapers turned black, and it is due to Alkaptonuria. And look at this person's hands, Alkaptonuria. The image is very high yield, so take note. Yeah, and they said homogentistic acid is toxic to the cartilage, so it destroys the cartilages. Homocystinuria. We also talked about this in the previous video, whereby we said, well, folic acid, that's tetrahydrofolate, is holding methionine or methionine, right? So folic acid, tetrahydro, TH, if I want to do it here, tetrahydrofolate is holding CH3, right? Because we said it's a CH3 donor, right? So it's holding CH3, right? And then it's going to give it to vitamin B12, right? It will give it to vitamin B12, and then it will turn into TH4. So TH4 will be here. It will become TH4. This side is not important to us. TH4. I'm sorry, but I have to do this. So it will become this TH4. But this side is not important to us. Now B12 will not be holding this CH3, and then it wants to form methionine. So methionine. So B12 will give the CH3 to homocysteine, this one, and to form methionine, right? So if somebody has and then the enzyme that mediates this is called methionine synthase, MS, right? So let's see how homocystinuria can form. This homocysteine here, which is here, right, is used to make cystathione naturally. That's what it does. It can also be used to make methionine. But here, if we lack methionine synthase, here, let's say we lack methionine synthase, it's not there, what will happen? The pathway will block, right? So if it blocks, the person will have accumulation of homocysteine, because homocysteine was used to make methionine. So if I block this, there'll be accumulation of this. Is that correct? That is correct. So that's one way of getting homocystinuria. The second way of getting homocystinuria is deficiency of this enzyme, which is called cystathione beta synthase. Cystathione beta synthase. Now, homocysteine can also be used to make cystathione, and cystathione will be used to make cystine, just as they have made over here. The enzyme here is the beta synthase, cystathione beta synthase. Cystathione beta synthase. That's the enzyme that mediates this pathway. Okay. So we can see that if I lack cystathione beta synthase, what will happen? We cannot convert homocysteine to cystathione. Therefore, we have accumulation of homocysteine. We have accumulation of homocysteine. So this is a classical homocystinuria, cystathione beta synthase. You have to keep it in your mind. And the other form is deficiency of methionine synthase. Also, B12 deficiency can also present with homocystinuria, because B12 deficiency also means that this pathway will not work. MS deficiency also means this pathway will not work. So we have to really understand this concept very well, because they can twist the question in many angles. So please learn the drawing very well. Learn this drawing very well. If you like, learn it according to the way I have taught it, because it's simpler that way than what they have done over here. So tetrahydrofolate, when we eat folic acid or we give folic acid to a pregnant woman, it's holding CH3 already, and then it will give the CH3 to B12. Then B12 will pass the CH3 to homocysteine. Then in that combination will form methionine. The enzyme is methionine synthase. So blockage of anything here, whether B12 is not there, methionine synthase is not there, and even if folic acid is not there, homocysteine will build up in the body. Methionine will be low. Right? Now, the problem in homocystinuria is that homocysteine is toxic to the endothelium of blood vessels, and that would cause what? It will initiate coagulopathy, because we said in coagulation, for someone to have coagulation, there are three triad. There's a triad, right? We said there is endothelial damage, there is a hypercoagulability state whereby the person is not moving or stationary, or the person is bedridden, they are not moving. So there's hypercoagulability state, and there is the third one is I think I've forgotten that one. But then you have to know that these things, they must, when there's endothelial damage also, there is also that is a needles for to initiate coagulopathy. So the problem with homocystinuria is that they have coagulopathy, and then they will start blood will start clotting in their blood vessels, and then we don't want that. So it's autosomal recessive, and then the causes that they've listed over here, I've talked about all of them. So the first one is cystathione beta synthase deficiency. We talk about it, that will accumulate homocysteine. Well, the next one is decreased affinity of cystathione for pyridoxal phosphate, that is vitamin B6, because here vitamin B6 is the cofactor. Therefore, if vitamin B6 deficiency can also means that this pathway will not work, so we'll still have homocystinuria. So just understand, don't memorize, understand, just understand like exactly what is happening in each of the states. Now the next one is the methionine synthase, which I explained here. So methionine synthase deficiency also means homocysteine will accumulate. And the next one is methyl tetrahydrofolate reductase deficiency, because here the enzyme that is reducing this to this, because removing the methyl group and it's giving it to this, is methyl tetrahydrofolate reductase. And if it's also deficient, it means we cannot pass the CH3 to B12, and that should make sense. All forms result in excess. So all the forms that we talk about, whether it's this, whether it's B6, whether it's B12 problem, whether it's this problem or whether it's this one problem, result in accumulation of homocysteine. Homocysteine will accumulate in the urine, and there'll be increased homocysteine in the urine, and there'll be osteoporosis, there'll be Marfanoid habitus. So they look like Marfan syndrome. The difference here is that in Marfan, they have upward dislocation of the lens. In homocysteine, they have downward dislocation of the lens. So Marfan and homocysteine, the eye lens, that's the difference. Presentation is the same, but the cause is different, of course, because Marfan is more hereditary. So the ocular changes, as they've said, downward displacement and downward in subluxation of the lens or displacement. Cardiovascular effects, they have thrombosis, that's the clots I was talking about, and atherosclerosis. They can also present with stroke and MI, because if you form clots inside your blood vessels, you start having stroke. They also have intellectual disability and kyphosis. Kyphosis is also more of Marfanoid, because they look like Marfan. Marfan presents with all those habitus, pectus excavatum, pectus carinatum, long limbs. And in homocystinuria, the lens is downwards and inwards. Marfan is upwards and outwards. Okay, let's go to cystinuria. Cystinuria. This is another simple and nice condition. I'm not saying it's nice to have, but I mean it's nice to learn. So in the proximal renal tubules and intestines, we are supposed to reabsorb certain amino acids so that we don't lose them in the urine, and also we don't lose them in the stool. For example, when I eat a certain amino acid, this amino acid, we need to absorb them so that we can use them for as building blocks in the body. And also in the PCT, we have to reabsorb them so that we don't lose them in the urine. But for some reason, there's a defect in the PCT, or proximal tubule, and then we lose all these amino acids. The mnemonic is cholecystine, ornithine, lysine, and arginine. We lose all of them in the urine. Cysteine is made of two cysteines connected together by a disulfide bond. So know the difference. This cysteine, which is the amino acid, is made from this cysteines combined. So excess cysteine in the urine will lead to recurrent precipitation of hexagonal stones, cysteine stones. So they'll have this kind of stones. This is how it will look like. And so that is cystinuria. A treatment is alkalinization of the urine and using potassium citrate or astazolamide that will alkalinize the urine. Because as this astazolamide works, it blocks the enzyme that helps us to form bicarb, right? It helps to so if I see O3, right? Yeah, so this bicarb should be reabsorbed so that we don't lose it in the urine, right? But then for some reason, if we give astazolamide, it's what's the name of the enzyme? Astazolamide, I think. Okay, I'm sorry, it has just skipped. I just had thought block. Yeah, okay, it's something I know, but I've just had thought block. Okay, so astazolamide, why would I forget this enzyme? Okay, let's continue. I don't want to waste time in this video, but you know it. So astazolamide just works to block that enzyme that should be forming by okay, carbonic anhydrase. I'm sorry. Okay, carbonic anhydrase. So carbonic anhydrase helps us to form bicarb, and then this bicarb will be reabsorbed in the PCT, right? Now astazolamide blocks that carbonic anhydrase, so we cannot form bicarb, so we lose everything in the urine, and then the bicarb will go into the urine. So if we give astazolamide, the urine becomes alkaline. Okay, chelating substances like penicillamine, increased solubility of cysteine stones. So penicillamine will help to dissolve the stones, and good hydration, give them a lot of water. Usually the answer is good hydration, and that is low in methionine, because we can use methionine to make cysteine, as we saw up there. Okay, it's autosomal recessive. Okay, Now let's look at the next one, the organic acidemias. They love this concept as well. They love this, but I'll make it simple for you. Okay, yeah, organic acidemias. Now, to understand this, I have to take you back to page, I think 74. Please open your books to page 74, organic acidemias. So I'm going to page 74 and this page 85. So we'll come back here. Page 74. Let's go there so that I teach you the organic acidemias. Then it will make things simpler for us, because I love to link things up rather than just learn everything in isolation. So this is what they are talking about in organic acidemias. Here, the odd chain fatty acids, and I told you what fatty acids are. So odd chain fatty acids are converted into propanol CoA, and valine isoleucine, and methionine and threonine, they are all also converted into into propanol CoA, so that they can go into the TCA cycle and be used to make energy. Now, when this happens, okay, propanol CoA needs to be converted as well into methionine. The enzyme here is enzyme number 22, propanol CoA carboxylase. It is adding a carbon. Propanol has 3 carbons. Propanol CoA has 3 carbons. Okay, it's 3 carbons, 1, 2, 3. Then after we add one more carbon here, methyl malonyl CoA, because metal itself is CH3, right? So that's 1 carbon. Methyl malonyl CoA has 4 carbons. So this is carboxylation reaction, right? Therefore, the enzyme must be a carboxylase, right? And all carboxylation, addition of carboxyl, I said it's done by what? B7, vitamin B7. So that'll be biotin, and it's right here. So like, these things are not hard, just know like the basics, the basic principle. Okay, now after this, we are going to convert methyl malonyl CoA into succinyl CoA, which also has 4 carbons. Therefore, we didn't remove any carbon. So the enzyme here is supposed to be methyl malonyl CoA mutase. Methyl malonyl CoA mutase is MMM. I love that. They didn't write it in the first aid, but yeah. So this is a mutase, and it's high yield. They test it, but it's not in the book. But these are some of the things. So in organic acidemias, it's either this is accumulating, methyl malonyl CoA is accumulating, or propanol CoA is accumulating. And how would they accumulate? It's either this enzyme is not there, the propanol CoA carboxylase is not there, or biotin is not there, or there is what? Accumulation of methyl malonyl CoA because this mutase is not there, or B12 is not there. So just remember, if it's, the question will be like this. The question would give you either they tested and propanol CoA is high, or both are high. Now, if only propanol CoA is high, it means that the deficiency is at this level. Then here will be low, right? Here will be low or normal. So take note, if methyl malonyl CoA is low, it means the problem is from here. If propanol CoA is high, it means the problem is here. But then, if both of them are high, okay, it means that the problem is from this angle. So please, let's take note. Okay, all right, so we can go on. But in both of them, we know, of course, succinyl CoA would be low. So it's either here or here. You can take your time to understand this, and it's high. They love testing on it. I told you this pathway here is very, very important. Yeah, take note. So B12 deficiency can present like this as well. So B12 deficiency can present with normal or elevated methyl malonyl CoA plus succinyl CoA. Both of them will be elevated. But then biotin deficiency, or the propanol carboxylase, CoA carboxylase, deficiency will lead to elevated this but low this. Just take note of that. So let's go to organic acidemias in our page 85. Good. So organic acidemias. So because of what we've just looked at, it makes it more simple. Now, most commonly presents in infants with poor feeding, and these are the presentation, vomiting, and that pathway we call it the vomit pathway. That's a vomit pathway. So the pathway I just showed with that yellow section is called the vomit pathway. So they have vomiting, because that's the mnemonic of the things over there. Hypotonia, they have high anion gap because of the organic acids, the propanol, CoA, and co, their acid. So, and then we also have hypertonically and seizures. So the accumulation inhibits gluconeogenesis because we cannot make succinyl CoA, which will go into the cycle to make oxaloacetate to go into gluconeogenesis. Therefore, they'll have gluconeogenesis problem. That means that when they are fasting, they'll have hypoglycemia. They also have ketosis because there'll be accumulation of the odd chain fatty acids that we saw over there. They'll also accumulate because everything is accumulating above. So the odd chain fatty acids will be used to make ketone bodies, and that will cause high anion gap. High anion gap means that the acid level is high. Okay. It also inhibits the urea cycle, leading to increased ammonia. Yeah, so take note of that as well. So the first one is the propanoic acidemia, and the next one is the malonic acidemia. So the propanoic one we saw over there is due to propanol CoA carboxylase, because we saw the carbon numbers deficiency, and that will lead to propanol CoA increase, but then malonyl CoA will decrease, and that should make sense. The second one is due to deficiency of malonyl CoA mutase, as I said over there, or the B12 deficiency, and we know that one will lead to elevation of both propanol CoA and methyl malonyl CoA. So P to the elevation of propanol CoA and also elevation of methyl malonyl CoA. So let's take note. All of them present the same, and you know these are the things that we saw over there: the valine, the odd chain fatty acids, methionine, isoleucine, and threonine. That's why we call it the vomit pathway. And so I think this makes it easy. This video we are doing today is, like, I would say 50% of your biochemistry questions are going to come from this video. So take note, 50% of your biochemistry videos are coming from 50% of your biochemistry questions, okay? 50% of your biochemistry questions are going to come from this particular video we are doing. So take note, okay? Yeah, if I were you, a day before my step, I'm going to review this particular video, and then you could just click your answers and come out. Yeah. Now let's look at glycogen regulation by insulin and glucagon or epinephrine. Very, very high yield as well. So this high yield as well. Now, what they want us to know is that in the liver and also in the muscles, this in the liver here, and this in the liver, certain things can regulate either formation of glycogen or breakdown of glycogen, because liver and muscle store glycogen for future use. The difference between them is that the liver stores glycogen, and then when we need it, it releases it for all the cells in the body to use. But then as for the muscles, they are selfish. They don't release their glycogen. Why? Because they lack the enzyme, the enzyme that does the final step of gluconeogenesis. That is glucose 6 phosphatase. Not the phosphate, but it's the phosphatase. Okay, because glucose 6-phosphate was the first enzyme that as soon as glucose enters a cell, it traps it with the phosphate. But this time we are removing the phosphate so that the glucose can leave the liver cells and go into the blood for maybe the brain or other things to use. So the phosphatase is the opposite of the glucokinase or hexokinase. Is that correct? Or the glucose 6-phosphate. Okay. Now, let's look at the pathway. This one means that you have to understand signal transduction. If you don't understand signal transduction, you want to go to endocrine. Endocrine has a mnemonic for the signal transduction, like what uses what. So just look, there's a mnemonic in endocrine and you will appreciate it. It's something high yield. I will treat that later, but we'll not go there today. So glucagon uses the cyclic AMP pathway. So glucagon will like for example, when we are in the fasting state, or when the person is going hypoglycemic, in the hospital we can inject them with glucagon. The pancreas can also make glucagon. So glucagon is released. Then glucagon enters into the cell and then binds to the glucagon receptor, right? And then it stimulates what? The adenylyl cyclase to convert ATP into cyclic AMP, as we see over here. Now cyclic AMP has what? Phosphate, so it can stimulate what? Protein kinase A, and the protein kinase A is the one that kinases all the proteins. And I told you that anytime you see kinase, it means addition of a phosphate. And phosphates in the body, generally 90% of the time when we are adding a phosphate to a substance, it is energizing it. Okay, so the energy in the body is mostly phosphate. It's always phosphate. 90% of the time, it's energizing the substance when we add a phosphate. So, and always phosphates, the kinases are always adding phosphate. So protein kinase means that there are certain proteins in the cell, we can kinase them, or we can add a phosphate to them to energize them. So protein kinase A, what? Kinases or adds a phosphate to this enzyme as well, which is the glycogen phosphorylase enzyme. And what does glycogen phosphorylase do? We said phosphorylation also means what? Adding an inorganic phosphate. So glycogen phosphorylase will activate glycogen phosphorylase kinase will also kinase this, right? Meaning that it's adding a phosphate to it as well. So glycogen phosphorylase kinase is kinasing the glycogen phosphorylase, right? It's adding a phosphate to the glycogen phosphorylase so that it activates it. And then when it activates this glycogen phosphorylase, it is going to break down the glycogen into glucose, right? It's going to break down glycogen into glucose so that we can release the glucose for the body to use. Conversely, when you have excess insulin, or you have insulin in the body, what the insulin does is that it binds to the tyrosine receptor. That's the receptor tyrosine kinase, right? Insulin will bind to the tyrosine receptor, and then it will also activate protein phosphatase. And we said phosphatases remove phosphate. So, but this protein phosphatase will stimulate glycogen synthase, so that glycogen synthase will be making glycogen So insulin helps us to make glycogen, whilst glucagon helps us to break down the glycogen. But you have to understand this pathway because they love to ask about it. So they will always ask about glycogen phosphorylase kinase most of the time. The answer will be glycogen phosphorylase kinase. But here also the answer will be, if it's insulin, it will be protein phosphatase. And also protein kinase A can also inhibit this, because when this pathway is going, when glycogen is working, it will be inhibiting the buildup of glycogen, because when glucagon is working to break down glycogen, you don't want to be building more of the glycogen. At that state, it's not a fed state, so we are not going to be building more, we are just going to be breaking down glycogen using glucagon, but insulin helps to build it up. Now, So this is the basic thing. There are other additions to this side. Now, for example, if somebody has been given epinephrine, or if somebody is in that active fight and flight state, whereby we have increased epinephrine can also bind to the beta receptors, for example, in the heart, right? And then these beta receptors can also stimulate the adrenal cyclase, and then they'll go through the same pathway and then release what? They'll release glucose for us to use. Same way, if you're under another form of stress, you can have the alpha receptors also from epinephrine, stimulate the alpha receptors to stimulate what? The endoplasmic reticulum. Endoplasmic reticulum stores a lot of calcium, so it releases calcium. Calcium can also activate all these enzymes. I said that yesterday. So muscle contraction, during muscle contraction, there's calcium calmodulin complex. That complex can stimulate the glycogen phosphorylase kinase. Remember this phosphorylase kinase, glycogen. So if I were you, I'll just picture this: insulin to my right, whilst glucagon to my left, because glucose has left. So glucagon to my left because glucose has left. And then we have glycogen phosphorylase kinase here, and then we have protein phosphatase. They always ask this to this one and this one. Take note. They always ask this. So this is very, very high yield. But they also want you to know that calcium can stimulate it, and also glucagon and epinephrine can also do the same thing. So take note of that. Now, glycogen. This is where we are going into formation of glycogen, and then we'll come to the breakdown of glycogen, and then we'll understand the glycogen storage diseases. Okay, I'm enjoying this because I love this side of the biochemistry. Yeah. All right. Now, I want to give you a brief overview of this before we start. So the story is like this. You've eaten a lot of glucose. You are not using it. What do we expect? The liver is going to store it, and then for future use. And when we need it in the future, we are going to break it down for use. But then what comes into mind is that, how do we store it? How we store it is that we take multiples of the glucose and put them together into a chain, and then they're just like beads, as we see in this image here. So they'll just be like beads, and then we store them. But are they going to be just beads that are very long, like a railway from here to Germany? No. We need to make them into like a ball, okay? Into a ball. So we don't just make it a straight line, but then at some point we have to make branches on them so that they become something like, let me see if I'll find this image. And I kept something here. Yeah, they become something like this. Good. There'll be something like this. So instead of making them into a straight line like this, we make branches on them, right? We make some branches on them so that they turn into a ball like this, and they can stay in the liver. Else they'll just turn into a very long chain, and then they'll prick the liver and go out and then be circulating outside. And then when we are walking, we'll have glycogen in front of us and it's leading us, and then someone will pull it, and then someone will pull our glycogen, and then we'll come back and somebody will pull it from this angle. So the body decides to make it into a ball. That is it. Now, this is how we synthesize glycogen. There is a certain protein in the liver called glycogenin. It's good to know it. Glycogenin. First of all, we make this glycogenin as the center of precipitation. That is where we start everything from. So we make the glycogenin. Then this is also a pathway, but then simply UDP UDP glucose will be made from we'll use this UDP glucose to add to the glycogenin so that we form this UDP glucose here. And the enzyme is a glycogen synthase. It's glycogen synthase that does it. So it adds UDP glucose, which has a high energy, attached to the glucose, and adds it to the glycogenin to make this. Now, when we go down, we want to make branches, so we make these branches. So understanding alpha 1,4 linkage and alpha 1,6 linkage, anytime you see the glucose in a straight line, it is an alpha 1,4 linkage. Anytime you see it branching at the point where they branch here, for example, where the branch is, that bond is the alpha 1,6 bond. But then when after the branch, all here will be alpha 1,4 branch, linkage, or it's a bond, alpha 1,4 bond. Okay, so that is about this also. That is about this one also. Good. Let's go back to what we were discussing. So if I want to show this image as well, it's like this. So if you look at this image, you'll see that here is between this, as they wrote right, between these ones is alpha 1,4, but where the branch, exactly where the branch is alone, here alone is the alpha 1,6 bond. So just take note, the glycogen synthase is the one that makes glycogen. And where we form the alpha 1,6 bond, where that's where the branch is, the enzyme there is called the branching enzyme, and that makes it simple for us. The enzyme is called branching enzyme. And then when we start breaking the glycogen to form glucose back, the enzyme that will break the bond is also debranching enzyme, because it has debranched, has removed the branch. So that also makes it very simple for us. So I think first aid makes it a little bit complex. We don't have to know to learn it the way they have done it, because they've put this Corey disease and everything together, and it's not the best way for me. So let's read this quickly. So glycogen has the alpha 1,6 bonds, which are the branching bonds, and also have the alpha 1,4 bond, which are the straight bonds. Skeletal muscles, glycogen undergoes glycogenolysis, that's breakdown of glycogen, and that leads to so the glycogen will add a glucose 1-phosphate and will get glucose 6-phosphate, right, which is rapidly metabolized during exercise. But it means that when we break down the glycogen, we add a phosphate because we don't want it to leave the cell, right? We add a phosphate, and so it becomes a glucose 1-phosphate. The glucose 1-phosphate will be converted into glucose 6-phosphate before it can be used. And the muscles are selfish, so they just use it because the muscles are a lot. They are a lot. They need more of even that than any other cell. In the liver does the same thing, but what the liver does is that it has a certain enzyme which is called the glucose 6 phosphatase. Okay, not the phosphate, but since we form the glucose 6-phosphate in the liver, the glucose 6-phosphatase will remove the phosphate so that the glucose can leak out of the cell. If somebody is getting lost, I don't want you to get lost, because that's why I'm doing this video. I'm taking you back to page 74 so that you will understand this well. Page 74. For me, it's better to take time to understand things once and for all than to rush and then say, oh, I understand it, and then be missing questions on it. Okay, so here we go. This side is for glycolysis. The first step is glucose enters into the cell, and then here is where we add the phosphate so that we get glucose 6-phosphate. The enzyme is this one, hexokinase or glucokinase. That's the enzyme that adds a phosphate to the glucose so the glucose does not leak back. Then we go into glycolysis. When we start gluconeogenesis, we are making glucose in the reverse direction to the glycolysis. So the gluconeogenesis, when we reach here, we will still form glucose 6-phosphate, but we said there was no way the glucose 6-phosphate can leak out. Therefore, we need an enzyme which is number 4, that is glucose 6-phosphatase, because we said phosphatases remove phosphate from the from anything, whilst the kinases add phosphate. So kinases will be here, whilst the phosphatase will be here. As soon as the phosphatase removes the phosphate, glucose will be free to leak out of the liver. This enzyme, the glucose 6-phosphatase, is not in the muscles. Muscles lack this, so please take note. Muscles lack it. It's high yield information. So let's go back to what we were discussing on page, I think, 86, I guess. Okay, Good. So this is where we were. All right. Good. So that's the difference. The muscles lack glucose 6 phosphatase, right? Glucose 6 phosphatase, not this. This is the substrate. This is the thing we get, the adding phosphate to glucose. But then removing the phosphate is done by glucose 6 phosphatase. So you always have, it's an enzyme, so glucose 6 phosphatase. This case is phosphatase, right? Take note of that. Okay, glucose 6 phosphatase. Good. Now, so the muscles lack this. They don't have it. Please take note. Hepatocytes, liver have it. So they can release the glucose for other parts of the cell to use. Okay, let's read this quickly. Glycogen is stored and undergoes glycogenolysis, that's a breakdown, to obtain or to maintain blood glucose levels at appropriate levels. Okay, glycogen phosphorylase liberates, as we saw in here, glycogen phosphorylase is the one that is removing the glycogen into glucose. Liberates glucose 1-phosphate residues of branched glycogen until 4 glucose units remain on a branch. That is low yield information. Nobody will test that. The 4-alpha D glucanotransferase, that's the D branching enzyme. The D branching, the one that will break the branches, moves 3 of the 4 glucose units from the branch to the linkage. Then alpha-1,6, that's a debranching enzyme, cleaves off the last residue. So what this thing is trying to say is that if we are supposed to be breaking this bond over here, we are going to cleave them into twos like this. Then the alpha-1,6 will break the last one. The debranching enzyme will break this one. So debranching enzyme will break. Debranching will break this one. But here is the alpha, this one, yeah, so here they wrote debranching here, and then they also wrote debranching here, so that makes the thing a little bit confusing. But I want you to know that over here it is the 1,4-glucosidase here, because it's a 1,4 bond, right? We said so. It's 1,4-glucosidase. We will see that later. That is the we'll see that later, so that we appreciate it. It's 1,4-glucosidase. It's breaking down let me see. Okay, 1,4-glucosidase. That is the enzyme. Okay, 1,4-glucosidase. That's what is breaking it down. Glucosidase. Yeah, that's what is breaking it down. So here 1,4-glucosidase will break here down. But when we reach here, the debranching enzyme will do that. So that's a simple analysis. Good. So now, if we understand this, we have to find a way to memorize the glycogen storage diseases. So in the glycogen storage disease, all they're trying to say is that there is a reason, okay, there is a reason why the glycogen that we have stored in the liver, now we cannot release it for other cells to use when we need it back, right? Because there is deficiency of these enzymes on the way, right? Okay. To make things more clear for you, the first of all, we have an enzyme that adds glucose to the glycogen chain to make it longer. Second, that is what the 1,4 will form this bond. 1/4 bond, right? Good. Second, that's 1,4-glucosidic bond. We have an enzyme that will form that. Second, we have an enzyme that will form the branch. That's a branching enzyme. Then, so at the end of the day, we need before we can release one molecule of glucose from the glycogen, we need an enzyme that will break this bond. That's a 1,4-glucosidase. We also need an enzyme that will break this one, which is a debranching enzyme, right? And that is it. After releasing it, the glucose is still in the cell, but again, we need an enzyme that will make it leave the cell by removing the phosphate. That is the one that we saw, which is the glucose 6 phosphatase. Glucose 6 phosphatase, only in the liver. So please take note. Now let's go to glycogen storage diseases. That makes this conversation interesting. Okay. Glycogen storage diseases. All right. Yeah, I love the way I understand it. Like I made it in my own way, and I hope it helps you also, because this can be confusing for students. Okay. So, first of all, we said there was a debranching enzyme that should remove the branches. Also, we said there is an enzyme that should remove the straight bonds, the 1,4-glucosidase, right? And also, we said there was an enzyme that is a branching enzyme that forms it, right? Branching enzyme. So this is an update. They've just added this to it. It wasn't part of them first. It's just an update. And then we also have the myophosphorylase, whereby in the muscles, as soon as the glucose breaks down, the muscles add a phosphate so that it does not leak. So that is the next one. So the myophosphorylase. Now the glucose 6 phosphatase was the one in the liver that removes the phosphate so that the glucose can leave the hepatocyte. Okay. The summary of this, like how I remember it, is that some of them cause hypoglycemia and some of them do not cause hypoglycemia. So those that cause, let's go to those that do not cause hypoglycemia first, is the MP, right? The ministers and the parliamentarians, they are rich already, so there's no way they can have hypoglycemia, right? But VC, which is von Gierke and Corey, have hypoglycemia. So MP are rich. MPs, the ministers and the parliamentarians, they are rich, so they don't have hypoglycemia. So you can see it over here. The MP, which is the McArdle and Pompey, have no hypoglycemia. And if you also know this man, if you follow US politics, you know Mike Pompeo. I also use that to remember him, Mike Pompeo. Is it Pompeo or Pompeo? Yeah, let's look at his image. He was Secretary of State to Donald Trump. You look at this man, you think he can get hypoglycemia because he's rich, right? Even if he's not rich, like he's a well-to-do man. He's not poor like some of us. So I use he's called Mike Pompeo. That's so MP, Mike Pompeo. So this is McArdle and this is the Pompey disease. So I use that as well to remember my mnemonic. Okay, so I said MPs, the ministers and the parliamentarians cannot get hypoglycemia. So MP and VC do not get hypoglycemia. Yeah. Next one, the next thing I do is that I know that this is the most severe form. So they get severe hypoglycemia, they get ketosis, and then a lactic acidosis, right? And then they can even get gout, right? Okay. Now, let's look at the Pompeo. That's the next one. That's the type 2. You don't have to know all this type 1, type 2. Nobody will test you type 1, type 2. They test you on the names rather, and you should know what is going on. So, Pompeo, the classic presentation is that their heart is large, so they have cardiomegaly, and then their tongue is very large. Yeah, and then they also have hypotonia. Yeah, and they've not written the tongue over here, but they also have very large tongue. Yeah, and because their heart is large, they cannot tolerate exercise, so they have exercise intolerance. So my mnemonic is that Pompeo hates exercise because of large heart. So most likely that is the one that will tell you has exercise intolerance. Yeah. So Pompeo Pompeo hates exercise because of large tongue. So that's how I remember it. So Pompeo hates exercise because of the large tongue, right? Okay. Or the large heart. I think that would be an exercise due to large heart, because they have cardiomegaly. Large heart. Sorry. Okay. Good. So that is the way I remember this. Okay, that is for me. Okay, if you can remember that, good for you. Let's go to Corey. So Corey is due to the D-branching enzyme. So similar to von Gierke, but this is a milder form of von Gierke, but normal blood lactate levels. This is something that you should know. It has normal blood lactate level. It can lead to cardiomegaly, but it's limits dextran-like structures will accumulate in the cytosol. So that if we are supposed to remove the branches and then we cannot remove the branches, then we will have what? Accumulation of something in the liver. So always when they use the word there's something that has accumulated or a limits dextran-like substance, is still the glycogen accumulating in the liver, you want to know that it is due to the D-branching enzyme, or it's due to Corey disease. So the mnemonic I use for this, I'm going to type it here. So Corey is a dextran D-brancher, but normal glucose. So that's what I write. So Corey is a dextran D-brancher. That's what I said, but glucose is normal. Yeah. So what happens is that sometimes they'll tell you Corey, just take note, because sometimes they'll tell you Corey has hypoglycemia. As I said over here, sometimes they'll tell you it does not have hypoglycemia. So just take note, because they said gluconeogenesis is intact. So in some states, the gluconeogenesis will be able to replace our glucose for Corey. At some time too, they will have hypoglycemia, because this gluconeogenesis does not happen fast enough, so they can have hypoglycemia. So just stick to the mnemonic, but know that Corey can vary. So Corey varies. So if here I can put glucose varies. So but glucose is high or low. Okay, high or low. It's high / low. So just take note of that. It's only Corey that behaves that it can. Corey is a dextran D-brancher, and that makes you know that it's a D-branching enzyme. Yeah. Now, Anderson disease. So this was updated in the 2019. It's not. So commonly, is most common presents with hepatosplenomegaly and failure to thrive in early infancy. Other findings include infantile cirrhosis, muscular weakness, and hypotonia. So all of them present like almost the same thing: hypoglycemia. Just differentiate with hypoglycemia or no hypoglycemia, cardiomegaly, no hypoglycemia. And if somebody has hypoglycemia, they'll always be weak, right? And also they have a problem with the branching enzyme, and then there's hypoglycemia occurs late in the disease. So this one is during the formation, the branching enzyme, not the debranching, formation of the branch. McArdle is another one that is highly tested. You can see that in the mnemonic, everything is M. Everything is M. So if you see the question is going after muscle, everything is muscle. See, myophosphorylase, and then they also have muscle cramps. They have myoglobin in the urine. It's McArdle. So just take note. One thing that you want to know for sure is that they have flat venous curve with normal rise in ammonia. Take note of this. If you can remember, flat venous curve is always Mercadal. So that's what I remember. So Mercadal has myoglobinuria. That is one thing you want to remember. They have a muscle cramps, and then also have the deficiency of the enzyme is the myophosphorylase that is deficient. So I hope this makes the whole thing easier for you to appreciate. Yeah, and let's go to the next page. Let's go to the next page, page 88. Yeah, this is another high yield lysosomal storage. And I could have done these videos separately, but let's do this lysosomal storage as well in this video, and so that it makes things easier as well. Now, lysosomal storage is another thing that students struggle with, because we've all struggled before with it. Yeah, but then you must find a way to remember it, and I'm going to show you how I did it. Okay, it sounds confusing, but actually it's not. You have to find a way of understanding all of them. Now, we have Taysachs, Fabry, metachromatic leukodystrophy, we have Krabbe, we have Gaucher, we have Niemann-Pick, and then we also have the rest here, Hurler and Hunter. Okay. What I do is that I assume that all of them present almost the same, right? Like the child will have weakness and all those things, but that is not classic to any of them. So I go after the classic presentations, because the question will always go after the classic presentations. Now, if you look here, cherry red spots, so let's differentiate them, because I told you that the boards want you to differentiate conditions, differential diagnosis. Okay, now cherry red spot in the eye, right, in the macula, cherry red spot. So this is Taysachs, right? It has cherry red spots in the accumulating of lipids, in lysosomes with anion skin, and no hepatomegaly. They have no hepatomegaly versus Niemann-Pick. Now let's go to Neimann-Pick and look at something. They have progressive neurodegeneration and hepatosplenomegaly. They have foam cells, and foam cells, that is lipid-laden macrophages, and cherry red spots in their eye. And it's due to sphingomyelin-myelinase deficiency. And then if we cannot break down the sphingomyelin with this enzyme because it's deficient, we have accumulation of sphingomyelin. In Taysachs is accumulation of GM2 ganglioside. They'll always ask it. And then the enzyme is hexosaminidase. Hexosaminidase A. Hexosaminidase A. The A is important. Good. Now, how do we differentiate Taysachs from Niemann-Pick? Because it's only the two of them that are similar. They always want you to differentiate both of them. So anytime you see cherry red spot, you are thinking Taysachs or Niemann-Pick. Now, Taysachs has no splenomegaly. Okay. So before I even say this, I would just want you to know that Neimann-Pick and Taysachs, okay, Neimann-Pick and Taysachs, Neimann-Pick and Taysachs both have cherry red spot. Neimann-Pick and Taysachs both have cherry red spots, right? What's the difference between them? Neimann-Pick has no Neimann-Pick has hepatosplenomegaly. Let me throw these things away. So Neimann-Pick has hepatosplenomegaly. No, this thing is bothering me. I have to find a way to use it. Okay, sorry. Yeah. So Neimann-Pick has hepatosplenomegaly. Whilst Taysachs has no hepatosplenomegaly. So that's what you want to remember when you're dealing with glycogen storage diseases, and then they start with cherry red spots in the eye. It's either Niemann-Pick or Tay-Sachs. The difference between them is that Neimann-Pick has hepatosplenomegaly. Tay-Sachs has no hepatosplenomegaly, and that gives you an answer to your question. So please take note. Again, when they talk about cherry red spots in the eye, it's three things that can cause that. In my studies, I discovered that it was three things. One is Neimann-Pick, Tay-Sachs, and the third one, can you guess? It's central retinal artery occlusion. That is off, but yes, you should know it. So as soon as you see cherry red spots in the eye, it's three things: Tay-Sachs, Neimann-Pick, and central retinal artery occlusion. That's what those three. Now, if the presentation is more like hypotonia, hyperacusis, and all these things, you know that you should be able to differentiate that the difference between Tay-Sachs and Neimann-Pick. Tay-Sachs has no hepatosplenomegaly. I can't stress so much enough again. Tay-Sachs has no hepatosplenomegaly. Now, next one, which other ones can we differentiate? Let's differentiate Gaucher and Niemann-Pick. Okay, these two. Now, they both have hepatosplenomegaly. Have you seen that? Both of them have hepatosplenomegaly. Now, apart from the enzymes that are deficient, for that we will surely know. Okay. Now, apart from that, the difference is that so the difference is that let me look at here. It's good. So the difference will be that Neimann-Pick has cherry red spot, whilst Gaucher does not have. But they all have lipid-laden macrophages, right? This one resembles tissue paper, right? And this also has lipid-laden macrophages, right? So they all have similarities, but this one has a tissue paper. So my mnemonic is Gaucher puts glucose in the tissue paper. For this, to remember it, Gaucher puts glucose in a tissue paper. They'll always say it looks like a tissue paper for Gaucher. And then Gaucher has what? They have bone breakage, like their bone always breaks. Like they have soft bones that can always break, so they always have fracture. Okay, so let me put the mnemonic here if you want to remember it. You want to differentiate Gaucher from Neimann-Pick, which is very crucial. So Gaucher puts glucose in tissue paper, puts glucose in tissue paper. This is how I remember it. Gaucher put glucose in the tissue paper. And so we should be able to differentiate both of them too, because they have both of them have hepatosplenomegaly, and then they all have lipid-laden macrophages. So just remember that both of them have a similarity, but then the cherry red spot can be a classical differentiation between the two. Also, these people have bone crisis. They have bone crisis, whilst Neimann-Pick does not have bone crisis. Why do I use this mnemonic? Gaucher put glucose in a tissue paper. Why do I use this mnemonic? Because because the accumulation is glucocerebroside, and then they also have what? Glucocerebrosidase as the deficient enzyme. That's why I say Gaucher puts glucose in a tissue paper. So as soon as I see the glucose, I know that it's glucocerebrosidase or glucocerebroside that is deficient. Among all of them, they are all autosomal recessive except the Fabry and down here Hunter, which are X-linked. Take note of that. Next, Krabbe. My mnemonic for Krabbe is the galactic crab came to destroy my eyes. So galactic crab, if it's crab, or you want to write crab as in K, that is crabby. If it's crab for K, or crab for galactic crab, or for the crab that we eat, put what? No, galactic crab destroy my eye, because this is the only one that has the eye, the optic atrophy or optic atrophy. Galactic crab destroy my eye. Okay, just to make sure. Yeah, so galactic crab destroys my eye. So if I see this mnemonic, then I know that in crabby it is due to galactocerebrosidase deficiency, and then they accumulate galactocerebroside, right? So these are my mnemonics that I use to differentiate them, right? Now let's look at metachromatic leukodystrophy. So here they have central and peripheral demyelination with ataxia and dementia, and it's due to aryl sulfatase A. Now, how do we remember this? Leukodystrophy. So I know that leuko is white cells, right? Leuko. So the mnemonic for this is aryls are, this one I took it from B&B. Aryls are white people. Yeah, the aryls are white people. If you know aryls, just Google who aryls are. Aryls are white people. If you just Google who aryls are, and then you will realize that they are white people. So it means that aryl sulfatase is for metachromatic leuko, which is white. Leuko means white, right? So aryls are white people. Okay, now let's see Fabry. Anytime I'm looking at Fabry, I say it loud. I stress on this A. Fabry meaning alpha galactosidase. So it happens in so it's a triad of it waxes and wanes, and it's a triad of episodic peripheral neuropathy, and then they have the skin findings. They are the only one that has skin findings. So angiokeratomas, and then hypohidrosis. They don't sweat much, and it can progress into renal failure and cardiovascular problem. So Fabry for alpha galactosidase. Now let's go down to the last one. These are mucopolysaccharides. The how do we call it? Glycosaminoglycans. Yeah, but these are sphingolipids. So these are just two, and that's good for us. We have Hurler and Hunter, right? Hurler is, take note, the L in Hurler means with alpha L iduronidase. Hurler, right? Now, the way I remember this is that they have they all have cause faces, right? They all have cause faces. They look almost the same, but the one that has aggressive behavior is the hunter, because when a hunter sees an animal, they become aggressive. So hunter has aggressive behavior. Again, hunter has no corneal clouding. Why? Because for a hunter to be able to aim at an animal to kill it, if it has corneal clouding, how can it see the animal? So hunter has no corneal clouding, whilst Hurler has corneal clouding. So that is how I differentiate it, and I'll always get my answer correct. Once I see corneal clouding, I know it's Hurler, because a hunter with corneal clouding cannot be a hunter. If you have corneal clouding, you have no business with hunting, because you need to be able to see the animal to target it. So for the enzyme deficiencies, Hurler has alpha L iduronidase, whilst the Hunter has iduronidase 2 sulfatase. Yeah, they'll put the 2. So if you see L for Hunter, you can choose it. If it doesn't comply with your your question, just take it out and you choose the other one. And they all have iduronate something in it. They all have same accumulation, heparan sulfatase and dermatan sulfatase. So this is very good. With all this, you don't need to memorize this chart. I don't need it. Okay, unless they bring you the table for you, they bring you this chart for you to put whatever is there. But apart from that, with all this we've just done, you should be able to remember this. Okay, so we will end today's video here, and then we'll start next chapter from fatty acid metabolism. So thank you very much for taking time to watch this video, and in the future we are going to do more videos. So please subscribe to this channel if you have not subscribed yet. Just subscribe. It will help me to get more views, and it also help the channel to grow, since YouTube looks at all these algorithms to suggest our videos to people. Thank you so much, and you should also share the video. I wish you good luck in your studies, and I want you to know that yes, you can do it, because we have done it. We've been through your stage before, and since we have done it, you can also do it. Peace out. Peace out. Okay.